We are live now. With all your permission, I'm starting
Yeah,
the
you can start.
session.
I have no issues.
Good morning, everyone present here. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, Dr. Anirban Sinha, sir. Sir has done MBBS, MD, DM in endocrinology, FACE from USA, and associate professor at Endocrinology Medical College, Kolkata. And today, sir is going to discuss on a topic hyperthyroidism and thyrotoxicosis. Let me tell you overview of the topic. Thyrotoxicosis is characterized by a clinical sign of abnormally high thyroid hormones action in tissues, whereas hyperthyroidism refers to increased thyroid hormone synthesis and secretion from the thyroid gland. This manifestation results from hormones excess at any level of thalamic, pituitary, thyroidic axis from the release of the induction of thyroid hormones. To know more about this topic, I would like to invite and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Yeah, thank you. Thank you very much for your kind introduction. And today I was given a task of talking about this particular topic, and I hope my screen is visible. Someone please confirm.
Yes,
Yes?
sir. It is visible, sir. Fine. Police.
Yeah, sure. Thank you. So today I'm going to talk about a very common problem, may not be as common as hypothyroidism, where thyroid hormones are low. Here the thyroid hormones are high. So this is a different concern. Let me remove the console first. So can you see my screen? Okay, fine. So
Yes, it's
we are,
visible, sir.
yeah.
First,
Yeah. So now we are talking about thyrotoxicosis. By definition, it is the state of thyroid hormone excess and not synonymous with hyperthyroidism, which is a pattern of excess thyroid function. So there are slightly, it looks similar, but there are slightly different presentation. But thyrotoxicosis is a hormone levels are itself excess, but hyperthyroidism can be of may not be of excess thyroid hormones sometimes, like the hormones with ACG secretion, which works as a excess stimulation of similar to thyroid hormone, and also present as a hyperthyroidism presentation, or maybe a thyroid hormone is not elevated, but destruction of the thyroid gland itself can release the thyroid hormone in one single go, and that present a symptom similar to hyperthyroidism. So coming to the thyrotoxicosis first, that is the excess thyroid hormone levels itself. It can be primary, that is a defect inside the body. That causes most common we see as we talk about is Graves' disease. That is the autoimmune stimulation of the thyroid gland causing the excess hormone secretion. It can be slightly middle-aged or elderly patients with toxic multilateral goiter. So goiters with multiple nodules in it, and that nodules itself is autonomous and activities which secretes the hormone levels. But in between the nodules, there is non-functioning thyroid tissue as well. So it is not a homogeneous activation of thyroid gland. Toxic adenoma is a single adenoma or the nodule which is secreting and hyperfunctioning as the autonomous function of thyroid hormone secretion. Functioning thyroid carcinoma metastasis, when the thyroid carcinoma which is metastasis peripherally, but still it is a character of the thyroid hormone secretion properties present inside. So it is if the very rapidly progressing tumors, there is a regression of the function, but with the thyroid hormone function, thyroid hormone production function of the metastasis is preserved, then there is increased thyroid hormone secretion from the metastasis itself. There may be another very rare causes like activating mutation of TSH receptor that causes by TSH receptor which stimulates the TSH which stimulates the thyroid gland. That receptor which is receiving the TSH hormone itself, that receptor is autonomously activated. Activating mutation is there. So even in absence of the TSH, the receptor is activated. So even absence of the TSH, the thyroid hormone production is excess. So that is autonomous mutation. There are some other receptor mutations like GS mutations like McCune-Albright syndrome, which is activating mutation of the GS, which increase the hormone levels. Struma overi, as I said, that ACG levels, which stimulates the thyroid gland, also cause the excess hormone levels, that is stroma ovariae. And drugs, even the iodine excess, uh, that is Jod-Besser's phenomena, even the patient takes excess iodine, but there is some inherent defect of the thyroid gland that can precipitate the slightly hyperthyroid state. Now coming to, we are discussing the thyrotoxicosis without hyperthyroidism. Like thyroid hormone levels are excess, but thyroid hormone symptoms are there, but thyroid hormone levels are not so high. Like thyroiditis inflammations, like subacute thyroiditis, or maybe the silent thyroiditis without pain or any other fever, local tenderness or anything not there, but still the silent thyroiditis is present. Other causes of thyroid destruction, as I was saying, like drug-induced destruction, like amiodarone, or radiation-induced, or infarction within the adenoma itself, cause release of the hormones without stimulation of the hormone, that is causing thyrotoxicosis without hyperthyroidism. Excess thyroid hormone itself, that is called thyrotoxic factor, but some patients with psychological disturbance maybe was given the patient of maybe a dose of 50 and patient is taking 200, 300 microgram of thyroid hormones, so that can present the excess thyroid hormone and precipitate the thyroidosis. Excuse me. Or patient is taking the thyroid tissue extracts. So this kind of presentation also possible without stimulation of the thyroid gland, patient has hyperthyroidism. There is secondary hyperthyroidism, that itself the TSH secretion is increased, like TSH secreting pituitary adenomas, or thyroid hormone resistance syndrome, where the TSH action is resistant. So the more amount feedback inhibition of the TSH is lost. So the more amount of TSH is secreted, and that increases TSH secretion, thyroid hormone secretion from the thyroid gland. Chorionic gonadotropin secreting tumor, as I was saying before, the gestational thyrotoxicosis itself, ACG in the pregnancy, can stimulate the thyroid gland. That is called secondary hyperthyroidism, where the defect outside the thyroid gland. Evolution of thyrotoxicosis. First, we measure the thyroid hormones, unbound T4, then TSH low, unbound T4 is high. That is suggestive of primary thyrotoxicosis. TSH low or unbound T4 is normal. We measure the unbound T3. If it is high, then only it is called T3 toxicosis. T4 is still normal, but T3 is high. Or if the patients of T3 is also normal, then it is called subclinical hyperthyroidism. It is a potential of progression to overt hyperthyroidism, or it can even go to euthyroid, or even in the certain 10-15% patient, it can even up to hypothyroid, because autoimmunity is a spectrum disorder. It can precipitate either hyperthyroid or hypothyroid both. Then if the patient of primary thyrotoxicosis, we look for the presence of Graves' disease, like orbitopathy, dermopathy, or this kind of presentation are there or not. If it is there, then it is suggestive of Graves' disease. It is not there, then we look for the other causes of thyrotoxicosis, as we have discussed before, like mantle-nodular goiter or toxic adenoma. They are the second most common things. We should be excluding them, like toxic mantle-nodular hyperthyroidism. If the patient has toxicity and feel is the nodular, is a suggestive of toxic nodular hyperthyroidism, it can be confirmed by the scan, or it can go for scan showing the low radionuclide uptake. Then we consider as destructive thyroiditis or iodine excess, or patient taking extra thyroid hormone from outside. Then the uptake scan will be low, but still the patient has symptoms of thyrotoxicosis. If the uptake scan is not low, then other cause of stimulation of thyrotoxicosis, as I was saying, ACG secretion either from the tumor or from the gestational thyrotoxicosis, can cause the stimulation of thyroid gland with uptake is high, but still the thyroid gland is not at fault. Other components are TSH is normal or increase or high T4 levels. Then both the TSH and T4 is increased compared to the normal hypothyroid. We consider that TSH is low and T4 is high. Here we see the TSH secreting pituitary adenoma. Those are rare, but thyroid hormone resistance, again, these are rare components. I'm not going to discuss in details, but if you exclude the other causes, the possibility still remains, though are rare, but still not impossible. In this situation, you refer to the patients to the endocrinologist, they handle it better. So TSH or unbound T4 is normal, then it is normal, and no further test unless the patient has other complaints otherwise. Coming to the hyperthyroidism, as I said, syndrome of hypermetabolism regarding excess quantity of thyroid hormone. We all know thyroid hormone is a catabolic hormone. So excess metabolism is there. It patient present with maybe most commonly the weight loss, because catabolism is excess. Ranges of subclinical hyperthyroidism to life-threatening thyroidostorm is possible. So you should to differentiate the mild thyrotoxicosis to the overt thyrotoxicosis and impending thyroid storm. Patient can be It can be deadly and can precipitate mortality as well. Major etiologies should be excluded, as I said before, like Graves' disease, toxic molecular goiter, solitary toxic adenoma, or maybe a simple thyroiditis which momentarily increase the thyroid hormone levels. But in studies, they have shown that it is more common in the women compared to the men, but men's are not excluded. So if the patients have symptoms, we should be evaluating the men's as well. So let us look at the common symptoms inside. We know that we all know that, but still as a recapitulation, maybe symptoms can be hyperactivity, irritability, dysphoria, forgetfulness, agitation, heat intolerance, sweating. Most common presentation may be palpitation, weakness, fatigue, or maybe weight loss. As I was saying before, still the patient has increased appetite. This is one of the classic example where weight loss is there in spite of increased appetite. Patient have hyperdefecation, not classic of diarrhea. There is a slight difference between diarrhea and hyperdefecation. Frequent stool is one of the presentation of thyrotoxicosis. Polyuria is possible. Oligomenorrhea, loss of libido is possible, more common in the men. Women. Signs includes tachycardia, atrial fibrillation is possible, tremor is there. Look for it when we see the patient of suspected thyrotoxicosis. Look for goiter, whether it is nodular or homogeneous, whether there is a tenderness, whether there is a bruit. We should be looking for skin usually presents with warm, moist skin. Lid retraction or lag is there. Gynecomastia is there. Muscle weakness is there. Should be looked for in all patients of thyrotoxicosis, and some patient presents with proximal myopathy as well. So squatting test should be done in the patients of suspected thyrotoxicosis. We look for the manifestation with concerns like cardiac manifestation. Patient has a palpitation, forceful heartbeat, high cardiac output, worsening of angina. The patient has ischemia underlying, so that ischemia is aggravated because of the increased cardiac function. And atrial fibrillation can precipitate agitation and irritability in the elderly patient, so that should be looked for. And honestly, atrial fibrillation may be the lone presentation of thyrotoxicosis in the elderly patients. Ophthalmic manifestation, the orbitopathy is present 20 to 40% of the Graves' disease. It can present simultaneously or it can appear after the Graves' disease symptoms are started. Chemosis conjunctiva or exophthalmos, watering from the eye, irritability in the eye. These are the common presentation and should be looked for in the patients of thyrotoxicosis. Graves' dermopathy, as we are saying, it's present rarely, but it is still possible to see, and 3% of the patient is there. It usually presents with erythematous thickening of rough texture of the skin with anterior lateral aspect of the lower legs or other places. This is how they looks like. This is the slightly Graves' orbitopathy, just a protruding eye or a staring eye may be the first presentation with the goiter. We look for this kind of patients to exclude the. This may look normal to you, but you should be vigilant to look for this kind of presentation and evaluate properly. CAS score is usually done for orbitopathy regarding the severity of the disease, activity of the disease, sorry, severity has a different score. So we can see in the second picture, this is more prominent with the congestion of the cornea. And there's, you can see in the lateral view, there is a proptosis of the eye. You can see eyeball is protruding from the normal orbit. And this is the severe form. There is extensive edema in the conjunctival edema. This is actually a conjunctival edema you see here, or there is edema in the lids as well. And this is again another presentation of. And these are the dermopathy, how it looks like in the hands. There is a hands also shows the clubbing of the hands is one of the presentation should be looked for. And this is the classical look of dermopathy, and this is the powdery orange, is commonly called as tethering of the skin is looked for. And this is how the skin looks like in the thyrotoxicosis. It's, as I said, it is rare, up to 10% is possible, but it should be looking for. This is acropathy. I was talking about digital clubbing, swelling of the fingers, toes, severe autoimmunity, high titer of thyroid stimulating antibody is a suggestive of thyroid acropathy. So we should be more careful, and these patients are more severe. Hypokalemic periodic paralysis is present in 15% of Asian or maybe also in white patients. So patient with the thyroidosis can present with periodic paralysis, not a classic paralysis, but intermittent paralysis with hypokalemia. That should be evaluated. GI manifestation, as I said, hyperdefecation, weight loss, complaints of abdominal pain is one of the presentation. Neurological presentation is the agitation is maybe the most common presentation, restlessness, confusion, delirium, obtundation, coma is extreme cases of thyroid storm. Myopathy, as I said, almost 50% of the patient, mostly the proximal myopathy. Hyperactivity of physical, emotional stimuli, fine tremors, as I seen in the hand, is possible. If you extend the hand, you can see it. And really periodic paralysis, as I said, 15% of the patient can have the periodic paralysis with hypokalemia. Thermoregulatory disturbance presents with a warm, moist skin, hot flushes, alopecia, and nail friability is also common in the thyrotoxicosis. Diagnosis commonly done with the laboratory measurement of TSH. It's suppressed, usually less than 0.05, along with the T4, T3 is elevated, or maybe slightly normal in the subclinical patients. And it's ideally, if you go for suspected Graves' disease or diffuse enlargement of the goiter, we look for TSH receptor antibodies, which usually very important for confirmation of Graves' disease. We do commonly the analysis of the levels of the antibodies, but ideally functional assays, if stimulating antibody or blocking antibody may be more faithful if we can do it. Not all the laboratories can do it. That is the problem. Secondly, if there is still suspicion persists, and honestly, I can tell you, routine radioiodine uptake is not recommended for Graves' disease diagnosis. But if there is suspicion to exclude from the thyroiditis, then we go for radioactive scanning, useful for diagnose and evaluate the thyrotoxicosis. And severity of the thyrotoxicosis can be detected by the X percentage of uptake, and that can help you to decide the dose of the radioiodine therapy if we give the radioiodine therapy later on. Thyroid sonography can exclude the associated nodules in the thyroid and goiter. It again routinely not done. If there is a nodular goiter, we can go for thyroid ultrasonography, and Doppler flow can be considered. It can be differentiating between the thyroid hypervascular states like Graves' disease and thyrotoxicosis, which are non-metabolic destructive thyroiditis, which are vascularities will be low, but in the thyroiditis or Graves' disease, vasculature will be high. Now coming to the adjuvant therapy beyond the antithyroid drugs, like beta blocker, we all know it is a very important drug to control the heart rate and tremor. It reduces the sympathetic and adrenergic activities like tachycardia, tremor, anxiety, palpitation. We also require calcium channel blocker for tachycardia like diltiazem from 60 to 120 milligram QID, and it decrease the supraventricular tachycardia, especially important for the risk of atrial fibrillation. Dexamethasone rarely required. If the patient has severe thyrotoxicosis, we can rarely require dexamethasone short course, 1.5 to 1 milligram for 2 to 5 days can help you out. Coming to the most important recognition of our antithyroid drugs. This is not antitubercular drugs. This is antithyroid drug. Patients with high likelihood of remission, patients, especially females with mild disease, small goiters, negative or low titer antibody should be identified. So these are the predictor of low early remission of the patients, and they respond better with the therapy. Elderly patients are with comorbidities, increasing the surgical risk, then we can go for antithyroid drugs always. Otherwise, surgery, radioiodine, and the antithyroid drugs are equal responsiveness, but most non-invasive maybe the antithyroid drugs. So it is always, most of the time it is tried first, but definitely patient should be given an option whether you want to go for surgery, whether you want to go for medications, or whether to go for radioiodine therapy can be given in the very beginning of the therapy. Individuals who may have limited longevity, so surgery may not be so much effective, or radioiodine therapy may be risky on these patients. Patient who had previously operated or irradiated neck, so operation is difficult. In the moderate to severe Graves' orbitopathy, when the radioiodine therapy is contraindicated, so it can aggravate the Graves' orbitopathy, then maybe the antithyroid drugs is working, maybe along with the steroid for that season for the Graves' orbitopathy. Radioiodine therapy is indicated for the females planning for pregnancy because antithyroid drugs are not usually, we do not want to use it, but we definitely can be used in the emergency, but do not want to use it in the routine pregnancy. So it's better in the planned pregnancy, go for radioiodine therapy with the, and it can plan pregnancy after 6 months to 1 year after the radioiodine therapy, it give a good outcome of the patient pregnancy. Individual, as I said, comorbidities with the surgical risk and radioiodine therapy can be given, or lack of access to the high volume thyroid surgeon or contraindication antithyroid drugs. Patient maybe is rash, allergies to the antithyroid drugs, severe hepatic impairment with the antithyroid drugs. Only option left with the radioiodine therapy is a possibility. Now coming to the indications, so very big goiter with obstruction in the neck or the thoracic inlet, respiratory distress is there, maybe the surgery is a better choice because radioiodine therapy can initially enlarge the thyroid gland, can aggravate the obstruction. Relatively low uptake of radioiodine, so radioiodine therapy will not be effective in that case. Maybe surgery is the only option. Suspected malignancy or non-functioning, hypofunctioning nodules are documented. Suspected malignancy again, coexisting hyperparathyroidism, other disease inside the thyroid gland, or females planning for pregnancy, as I said, radioiodine therapy or the surgery is the better option, because we do not want to continue antithyroid drugs during pregnancy. A patient with a moderate to severe Graves' orbitopathy, again, the radioiodine is contraindicated in that situation. So we can go for surgery in this patient to debulk the thyroid tissue and load of the antigen itself. The precipitate of the Graves' orbitopathy is low, and so Graves' orbitopathy can respond with surgery itself. Very important to remember the contraindications of different situations, like uh, a pregnancy and lactation is a contraindication of radioiodine. Coexisting thyroid cancer, we do not want to give it. Individuals unable to comply with the radiation safety guideline, definitely there are guidelines, and patient with having small children at home have to stay with the children. In this situation, maybe we do not want to give it. Planning pregnancy within 6 months, in the females, we do not want to give radioiodine therapy. And antithyroid drugs, definitely allergy to the any drug or rash, liver impairment, or any other rare adverse events of the antithyroid drugs is a contraindication. And contraindication through the surgery, maybe the previous surgery is one of the important contraindication. Comorbidities like cardiopulmonary disease, where the surgery itself is risky, or patient has a in pregnant with the already first trimester, third trimester pregnancy, because these are not commonly tried. Only the second trimester patient can be tried with the surgery, even in the patient is pregnant. So treatment of thyrotoxicosis includes antithyroid drugs. It actually inhibits the formation of thyroid hormones by interferes the incorporation of the iodine into tyrosyl residue of the thyroid globulin. Commonly use the carbimazole or methimazole. Carbimazole maybe 30 to 40 milligram. Methimazole is almost similar dose. It is almost 20 to 30% more potent than carbimazole. So throughout the world, it is more used as methimazole, 30 to 40 milligram daily. It can be either once daily or in the divided dose, depending on the aggravator of the symptoms. Initial part may be given in the divided dose. Later, we can make it single dose treatment. Therapeutic uses includes other say disease like congenital radioiodine therapy may be required if the patient is not responding to radioiodine therapy. Commonly, we try it for 1.5 years. Most of the patient go for remission by the time. If it is not getting remission more than 1.5 to 2 years, then maybe we go for radioiodine therapy after that. We should remember the side effects, as I said, rash, urticaria, fever, arthralgia. Less frequent as the stiffness of the joint, nausea, skin pigmentation, hair loss. Rare side effects, but serious side effects include hepatitis, nephritis, agranulocytosis. Again, if the patient is suspected with fever, cough, after the antithyroid drugs are started, we can go for blood count as well to exclude the agranulocytosis in these patients. Iodides are required for preparing the patient for surgery, maybe. Its high concentration of iodide influences the iodine metabolism. It inhibits the again the incorporation in the Ulchikov effect. Minimum effective dose is 6 milligram iodide per day. Strong iodine solution, that is Lugol's iodine, is commonly used till now. Is the 3 to 5 drops TID, and SSKI, or the saturated solution of SSKI, is also available. 1 to 3 drops TID is a normal therapeutic dose. Preoperative is most commonly used. Prepare the preparation to make the gland solid, and release of the hormone is less. And it should be used along with antithyroid drugs and propranolol. Side effect is always to be kept in mind, like the angioedema, laryngeal edema, skin reaction, gastric irritation, diarrhea, thrombocytopenia, fetal periarteritis nodosa is a rare complication again. Radioactive iodine, as I said, it usually get trapped in the thyroid gland. It destroys the thyroid gland from inside, from the colloid in the follicles. Usually 7,000 to 10,000 rats per gram of thyroid tissue is administered. Millicurie is usually given. Almost commonly we give the 10 to 15 millicurie is sufficient enough from normal Graves' disease, but it can be requiring higher dose if the tissue volume is high or the activity of the gland is high. We can require a higher dose. Therapeutic use is mostly in the hyperthyroidism in the beginning, or maybe not responding to antithyroid drug for more than 2 years. It can be a concern, possibility, but we should remember the radioiodine destroys the thyroid gland, so there is a chance of delayed hypothyroidism. In the long term, patient may require thyroid hormone replacement, or in the patient of the uncontrolled thyrotoxicosis. That's why I said initial ATD should be given before radioiodine therapy. It can precipitate the thyroid storm as well, or in the presence of thyroid orbitopathy, it can aggravate the thyroid orbitopathy if unless given along with the steroid. So this is the ATA 2016 guideline. We measure the antibodies, radioactive iodine uptake, if possible. measure the technetium uptake should be obtained for the clinical presentation. We exclude the causes we have discussed before. We should be excluding the thyroiditis from the thyrotoxicosis, like the Graves' disease. Also, we exclude the multinodular goiter, toxic multinodular goiter should be looked for. And in the choosing in the different patients, firstly, maybe propylthiouracil is not commonly used nowadays, maybe only used in the first trimester of pregnancy, or maybe in the thyroid storm when the rapid activity is required. In the patient with the minor reaction to MMI, we refuse radioiodine. In cases also that propylthiouracil can be used, but require a single significant higher dose. Patient should be informed about the side effects of ATD. As I said, please write down the concern that if any reaction or side effects appear, please inform immediately and stop the ATD. That should be written in the prescription to avoid the complications. Before starting the ATD, each subsequent visit, patient should be alerted about the medication, like the look for the serious complications like agranulocytosis or hepatic injury. If concerned, we look for the liver function test or blood counts. And differential blood count should be obtained during the febrile illness, as I said, to exclude the agranulocytosis in the even in the mild pharyngitis can be a person, and explain the patient about the risk of periodic rash, jaundice, dark urine, joint pain. These things, antibody levels are very important prior to stopping of antithyroid drugs to suggest that it can predict the improvement of the response or warning the medications. Calcium and vitamin D should be assessed preoperatively and repeated if necessary to given prophylactically. Almost, as I said, it is a hyperactivity disorder or the metabolically active. So maybe calcium supplementation may be required initial part of the antithyroid therapy, because bone mineral density also goes low in the active thyrotoxic patient. So calcium supplementation can improve the bone health in the initial part of the antithyroid drugs, along with, or in the patient has surgery, postoperatively calcium supplementation may be required as well. If the exceptional circumstances when the patient the Graves' disease cannot be made euthyroid before surgery, then patient when they allergic to antithyroid drugs, so extensive beta blocker steroids are required, and to immediate postoperative period to prevent the thyroid storm. ATD should be stopped at the time of the thyroidectomy in the Graves' disease, and beta blocker should be burned following surgery gradually, depending on the response of the patient. Following thyroidectomy, levothyroxine or the thyroid replacement should be started in the lower dose, and elderly patient needing some or less dose. So we should monitor the TSH every 6 to 8 weeks intervals and titrate the thyroid replacement in the post-surgery level, because if the thyroid gland is removed, thyroid requirement should be come from outside. MMI should be used in children who are treated with antithyroid drugs. ATD should be stopped with the blood count in the children who develop fever, arthralgia, mouth rashes, and PTU should not be used in children. As I said, radioiodine uptake should be near zero in the patients with painless thyroiditis, factitious thyroiditis when the excess thyroid hormone taken from outside, or recent excess of thyroid intake, mostly iodine intake. Mostly it can be on the excess seafood taken, that can a potential source of excess iodine intake, or maybe iodine syrups containing syrups, cough syrups can also be a source of excess iodine intake. So this situation, radioiodine uptake will be low as even the patient have thyrotoxicosis. That should be kept in mind when we decide it. As I said, it is radioiodine therapy is a single shot therapy, does not require continuous follow-up and monitoring. So it's sometimes preferred in the patient as a difficult to follow up, and patient cannot follow up, or we cannot monitor the levels regularly. Maybe the radioiodine can be offered in the first place. It has a better quality of life outcomes. So there are different outcomes. Thyroid malignancy, radioiodine therapy is not to be given in the situation. Antithyroid drugs or surgery is the preferred indication. And definitely patient choice is important. As I said, it is almost like a cafeteria choice. Patient can choose any of the antithyroid drugs or radioiodine therapy or surgery, depending on their situations and their ability and the affordability, and many situations are concerned, like the pregnancy plan, like the patient has the elderly patient, as the comorbidities, risk for surgeries, everything should be kept in mind when we decide the treatment of the patient. And ADA guideline, American Thyroid Society Association guideline shows all the patients with symptomatic thyroidosis beta blocker should be recommended, and resting heart rate should be monitored. The radioiodine therapy has been used to treat hyperthyroidism for more than 7 decades, so it is very effective. Can induce a short-term thyroid increase in the thyroid hormone level. So post radioiodine therapy, beta blocker, antithyroid should be continued, but prevent the clinical exacerbation of hyperthyroidism. after radioiodine therapy may be considered in the patients with severe hyperthyroidism, elderly, presence of atrial fibrillation, renal failure, trauma, presence of associated infection, poorly controlled diabetes. We commonly see diabetes with thyroid disease nowadays. So this situation, antithyroid drugs may be considered along with. So administration radioiodine usually considered is, as I said, sufficient of radioiodine should be administered, like the mean dose around 10 to 15 millicurie to prevent the patient euthyroid. A pregnancy test should be obtained 48 hours prior to the treatment. That is very important. Even if the patient is unknowingly become pregnant, so that should be excluded. So pregnancy test should be done before going for radioiodine therapy in the woman of childbearing age. Success of the radioiodine therapy strongly depends on administration access. So in the patients without adjuvant and antithyroid drugs, RCT shows 61% success with 5.4 millicurie, 69% 8.4, and 86% with 15 millicurie. So we understand the higher the dose, success rate is more. So we commonly try to go for more or higher dose, around 15 millicurie, preferably if the patient is seriously active. So that should be kept in mind. Try to give a higher dose to get a complete remission compared to the lower dose, which was given before in previous concept. Follow-up is usually recommended 1 to 2 months after radioiodine therapy, because by the time the revolution of the gland occurs, biochemistry monitoring done 4 to 6 weeks interval for 6 months until the patient becomes hypothyroid. Then the patient's thyroid hormone stable dose of thyroid replacement can be continued. When hyperthyroidism due to Graves' disease persisted after 6 months following radioiodine therapy, we plan for a repeat therapy because initial therapy is considered not fully effective. Repeat therapy with a slightly higher dose can be considered. So with this, I end my talk here. So any question is welcome from your end. So over to the meeting coordinator.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participant doctors on their practice also. Sir, we have received some questions from the participant. If you allow, can I take these questions?
Yeah, sure. Go on.
The first question I can see is, how does the incidence of hypothyroidism vary by age, and what are the morbidities associated with hypothyroidism?
Hyperthyroidism, you mean, right? We are talking about
Exactly, sir.
hyperthyroidism today.
Exactly, hyperthyroid.
So what we want to say is that hyperthyroidism per se is a disease mostly in the middle age, but it has been seen in the young, very young child as well. We do see as an endocrinologist, but it is not very common. I really expect that. So but what I mean to highlight is that even in the child of 3 to 4 years, even 5 to 6 years, if the patient has the obvious symptoms of thyroidosis, please do not ignore that it cannot be a thyrotoxic, because in this age. So most common age is around the middle age, not in the elderly. Elderly, the thyroid toxic nodular goiter is more common. Middle age, the Graves' disease is more common. Again, as I said, women are more commonly affected by than men. But again, men do have the Graves' disease as well. So again, by age and by sex, do not discriminate altogether. If the patient has symptoms, they are more definitely need to be evaluated for the Graves' disease or thyroidosis. So, but more common in the middle age and more in the females. Otherwise, but still possible in the extremes of ages, as early as 3 to 4 years is also possible. We have seen patients of 3 to 4 years with Graves' disease. Even there are features of there is a different entity, the neonatal thyrotoxicosis. It is still possible at birth. There can be a thyrotoxicosis. That is a different spectrum disease. We are not going to discuss today. But even the neonate can have thyrotoxic feature as well. Next question.
Okay, thank you so much, sir, for answering it and explaining it really well. And moving forward, I can see another question is, how does iodine included thyrotoxicosis occurs?
See, in nutshell, that iodine is the source of thyroid hormone production. So if the patient has normal patient like you and me who are not patient actually, normal person can filter the uptake of the iodine in the thyroid gland even if you give the excess thyroid iodine levels. But there is some intrinsic defect in the thyroid gland which the iodine uptake is not regulated, or the thyroid hormone production is not regulated. In that situation, if you give the excess iodine levels, which is get incorporated inside the thyroid gland, which is thyrothiorenin and tetrahydrothiorenin production is increased inside the colloid of the thyroid gland, thyroid cells. I mean, the colloid thyroid acini. So in that situation, the excess production of thyroid hormone will occur because of the excess availability of the substrate. Iodine is actually a substrate of the iodine thyroid hormone. So if the excess substrate is available, it does produce the excess hormone level as well. So that can precipitate the iodine excess with thyrotoxicosis.
Okay, thank you so much, sir, for answering it really well, sir, once again. And moving forward, the third, I can see there is couple of more questions. And the third question is, what is the role of thyroid stimulating immunoglobulin, that is TSI, measurement in the workup of hypothyroidism?
As I said, I have discussed it in the slides if you have looked for, because it is recommended, it is to be done, may not be done routinely because of the cost, but it gives you an idea about the severity of the disease. It gives you an idea about the prognosis of the disease, that how it is going to respond with the antithyroid drugs or the radioiodine therapy. Higher the titer, response rate is poorer, or the patient require higher dose of the radioiodine, maybe if the antithyroid anti-TSH receptor antibody titer is high. And also in the pregnancy with the Graves' disease, then the titer depends the prognosis of the outcome of the pregnancy as well. High titer in the pregnancy with Graves' disease, the response rate and the risk of the fetus is more in the antithyroid drugs should be used wisely in this situation. And also, ideally, as I said in the discussion and the lecture as well, that it ideally should be done for the functional assay, thyroid stimulating antibodies or thyroid blocking antibody if possible. There are labs to do it, but not routine labs does it. So if possible, it should be done, because blocking antibody actually precipitate the hypothyroidism. On the other hand, thyroid stimulating antibody can precipitate the Graves' disease. So that again explain how the spectrum disease of autoimmunity can precipitate both Graves' disease and hypothyroidism together. And also the Graves' disease in the even without treatment can end up in hypothyroidism in the long run. So this is actually a spectrum. We need to monitor the patient regularly to prevent the progression of the disease from one end to other. Next slide. Next question.
Okay, sir. Thank you so much, sir, and for answering it. Sir, last question we will be taking for today's session. And the question of what are the differential diagnosis for hypothyroidism and thyrotoxicosis?
As I said, there are slides we have discussed. So we need to evaluate the causes of the thyrotoxicosis per se, and hyperthyroidism without thyrotoxicosis. As I said, the most common presentation may be the patient taking extra thyroid hormone or overdose of thyroid hormone that can precipitate it, or the struma ovariae can precipitate it, or patient has destructive thyroiditis. As I said, amiodarone or radioiodine therapy in the radioiodine radiation exposure, not radioiodine. Radiation exposure in the neck because of some other cancer or something that can destroy the thyroid gland and release the thyroid hormone from the destroyed gland and precipitate thyrotoxicosis. And also by symptoms like palpitation, tremor, we exclude the other sympathetic hyperactivity, even the pheochromocytoma on the hormonal levels, or the simple tachycardia, atrial fibrillation itself can simulate the thyrotoxicosis. Again, that should be excluded. To confirm the thyrotoxicosis. Definitely, the thyroid hormone levels will be altered compared to the other differential diagnosis of the thyrotoxicosis. Thank you.
Okay, thank you so much, sir, for answering it. As I can see, there is no more question from the participant end, sir. As there is no more question, shall we conclude this session with all your permission?
Yeah, I'm open, and so it's okay. Then we can conclude the session. So
Okay.
thank you for arranging the session. I hope it worked for the people
Yeah,
who
sir,
listen to
sure.
it. So
Uh,
thank you very much.
yeah, thank you so much
Well,
for
bye.
taking out your sir, precious time, and hope to see you again with different topic. Till then, take
Okay,
care
sure.
of yourself. Thank